Welcome everyone to today's webinar, The Business of Orthopedics in Spine and Surgery Centers. I am Brian Zerman, the Custom Content Editor with Becker's Healthcare. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And at this time, it is now my pleasure to start today's webinar by introducing our presenters from the National Medical Team. Nader Sami is the Chief Executive Officer. Kylie Kaiser is the Senior Vice President in Clinical and Regulatory Affairs. Scott Allen is the Vice President of Managed Care Contracting. And at this time, I'm pleased to turn the floor over to Nader to begin today's presentation. Take it away.
Thanks so much. We are really excited to be here today to talk about one of the more interesting areas of healthcare today. So within the surgery center world, obviously there's a lot of excitement and growth in this space for a lot of reasons that we'll talk about today. And specifically, we're going to really focus on orthopedics and spine, what's happening in ortho and spine and surgery centers, and really kind of hone in on the business elements of that, and discuss the trends and the opportunities. And so we're excited about that. And so just briefly, we'll give you our backgrounds. I'm the CEO of the company, of National Medical. National Medical is the largest ASC revenue cycle and consulting company in the U.S. We have over 300 surgery centers and surgical practices that we do work for. And our work consists of everything from managed care contracting to medical coding, the full revenue cycle services, the full billing and revenue cycle services that wrap around that, including very detailed analytics to help inform all the surgery centers about their business so they can make good business decisions. We also provide strategic and financial consulting services that help our clients strategize on growth opportunities and financial improvement for their organizations. And then just briefly, prior to National Medical, so I've been CEO of the company for 10 years now, but prior I started my career as a corporate finance attorney and then moved into investment banking in New York and San Francisco, where I worked heavily in mergers and acquisitions and taking companies public, et cetera. And then in 2000, I started a healthcare revenue cycle company that was focused more on the hospital and on the physician side of things. And we built that company up to about 2,500 employees and ended up selling that before I came on and joined National Medical in 2010. So with that, I'm going to turn it to Kylie.
Thank you, Nader, and hello, everyone. My name is Kylie Kaiser, and I serve as the Senior Vice President of Clinical and Regulatory Affairs at National Medical. I am a registered nurse by trade, previously working in the hospital intensive care unit, and then spent over 7 years as an RN and an administrator in a spine-focused ASC, overseeing operations of the Spine ASC, its affiliated clinic, and diagnostic center. I now focus primarily on revenue cycle compliance for ambulatory surgery centers and advocate in Washington, D.C. for legislation that supports our industry. Happy to turn things over to my colleague, Scott Allen.
Thanks, Kylie. Scott Allen, Vice President of Managed Care at National Medical. I've been with National Medical for over 12 years now. My role is the strategy and direction of all aspects of managed care and development of best practices throughout the revenue cycle. Thanks.
Thanks, guys. So in terms of just big picture agenda, what we're going to cover today, we're going to focus on trends driving growth in the ASC market in general, specifically the hyper-growth of the ortho and spine specialties within the surgery center market, the financial impact that can have on your organization, and then we're going to jump into clinical and regulatory considerations, managed care contracting details to make sure you're maximizing your opportunity here, and then finalize with highlighting the critical steps to take to make sure that you can capitalize on the trends within this market. So as we jump here into the growth trends in the market, if you look here, projected growth within the ASC market is really significant. as I mentioned, the surgery center market within all the healthcare different areas, surgery centers are growing faster than any other part of the market. As you'll see here on this chart, revenue within surgery centers from 2015 to 2021 is projected to grow from $28 billion to $43 billion. It's a $15 billion movement of revenue into this space, which is 54% growth in a 6-year period. Very powerful. But what's really interesting is if you looked at this and look at the procedure growth from 20 to 27 million is about a 35% growth. So you have outsized revenue growth. You're growing 54% revenue on 35% growth in procedures, which really highlights the movement of the high acuity, high reimbursing type of specialties, highlighting that movement from inpatient toward hospital outpatient to the surgery centers today. So very interesting, as I mentioned, great time to be within this market, and ortho and spine are two of the fastest growing specialties within surgery in the surgery center market today. So, we look at this and the question is why? What's driving that growth? Well, there are numerous trends here that are entirely in favor of this movement and are creating this opportunity. And one of the things that we talk about here a lot is that there's very few times in life and anything in life that you have a win-win-win situation. And if you look at the constituents in this market, you have patients, you have surgeons, and you have the payers, and we would incorporate employers as a payer in this world today. And so from that standpoint, when you look at this from a patient perspective, you have a wonderfully attentive, convenient, easy environment to get scheduled in, get taken care of, great attention, and at lower cost. So we're finding that patients who have the surgery center experience are significantly happier with that experience than, for example, being in an inpatient environment. Surgeons have, again, same idea, same flexibility in their schedule, flexibility and control of staff, of technology, and also have the opportunity to have equity ownership within a facility. And so there's also financial upside from a surgeon's perspective. And then from a payer perspective or employer, it's quite straightforward in that scenario, significant savings. You're looking at 40 to 60% type of cost savings in that movement from the hospital to the ASC setting. And now that there are, with some of these other points, technological advancements, creating great outcomes so that they're safe, high quality, great outcomes in a lower cost, more convenient setting. And so those are major drivers. In addition, of course, we have an aging population. So when you kind of look at all those components, you see what's driving this movement to the surgery center market. There are a couple other interesting points that I think are also driving. There's recently been an initiative. So CMS has actually started to approve more and more. We'll talk about that here with total joints, for example. They're approving more and more types of cases in ASCs than they ever have before. They're following on the behind the commercial payers, but they're coming pretty quickly. And there was an interesting initiative here on March 31st of 2020 as a result of COVID called Hospitals Without Walls, and that is where CMS has allowed surgery centers to essentially enroll on a temporary basis during this public health emergency as a hospital and able to take inpatient and hospital outpatient cases to the surgery center. And why I bring that up in this context here is that it is going to give more and more data to the surgeons and have surgeons doing more of these cases than they've done before. But more importantly, CMS is going to have data with respect to quality, and they'll see what they can do from that perspective and see the billions of dollars of cost savings that can be generated if they accelerate that movement. So I think that's a big driver. And then finally, COVID, while it's obviously been a painful year for everyone in so many different ways, I do believe that COVID on a long-term basis has actually underscored the value of surgery centers and the safety of surgery centers relative to going into an inpatient environment where, for example, today they're, the COVID patients are in the hospital, and you have the opportunity to have surgery done in another setting. So the message, I think, has been understood by probably all of us who are on this call as to some of the value of surgery centers. But the mainstream patient on the street is now, for the first time, really, it's being highlighted to them, the potential concerns of some of the viruses and such that exist, where you have other sick patients in hospitals that do not exist in that ASC environment. So with respect to that, the orthopedics and spine has really seen a hypergrowth and is going to continue to see hypergrowth in the market. So we see over the last 5-6 years, 31% growth in ortho and 200% projected growth in spine. But this is on a procedure level basis. When you look at revenue, that ortho growth rate will even be higher because of the types of procedures that are moving. And so, for example, due to the technology and aging population points that we talked about earlier, hip and knee replacements overall, regardless of the site, are projected to grow at 25 to 30% over the next 5 years, with a major movement on those cases to ASCs due to CMS obviously approving and some of those other reasons that are driving those cases to surgery centers. And so we have about 1.7 million knees and hips, total knee and hip surgeries happening today, and that number is projected to grow dramatically here over the next 5 years, again, as the population continues to age, with well over 50% of those cases projected to be performed in surgery centers. And I'm not going to spend too much time here on these next couple slides, but this is just to highlight some of the types of procedures, orthopedic procedures, that are being performed today in ASCs. Obviously, we talked about total knees. That was approved in 2020 by CMS, but it had, many people have been doing them on a commercial basis over the last few years. Now we have total hips coming in 2021 for Medicare cases, and obviously a lot have been doing total hips in ASCs already. And then, of course, you've had the rotator cuffs and tendon repairs and wrists and labrums, etc. So it is, I was talking to some orthopedic surgeons the other day, and they believe over the next few years that 75% of their surgical cases could be performed in a surgery center environment. So with respect to spine, really the same movement. Spine is, I would say orthopedics is more mature in its development right now than spine. Spine is newer, but there's been a major movement of spinal fusions moving to surgery centers, and those are obviously big ticket items. And you've got the laminectomies, but really the movement of fusions is significant, and every day we're seeing CMS approve more and more cases from a spine perspective to move over. Before I turn it to Kylie, there is this, I think this is one of my favorite slides to really go over to highlight the financial impact of everything we talked about. So we've talked about big picture kinds of procedures that can move, that these are high acuity, higher reimbursing type of procedures. So here we're just going to walk through the financial impact of taking a multi-specialty center and adding, for example, a total joint program or adding fusions. And so we took an example here. And the example is we're taking a 300 case per month surgery center that's averaging about $2,000 cash per case, so $600,000 a month. So you've got a $7.2 million center at a 20% margin, is making $1.44 million of EBITDA. That's its profit. So a business like that in this market, 7 times EBITDA is probably a fair valuation multiple for that business. So hypothetically, this business of the profile I just described is worth about $10 million, which is great. Now what we're going to do is look at, if you take that same center and you recruit a surgeon over or create a strategy to bring total joints or even these numbers are more conservative than fusion. So let's discuss total joints from that perspective. $11,000 cash per case. So in this scenario, you're going to take a 300 case per month center and add only 30 cases. So about a 10% increase in your volume at $11,000 per case. So that's going to add $330,000 a month, or another way of saying that is $4 million of additional revenue. So you've increased your revenue by about 60% relative to where you were by adding only 10% cases. But these are very profitable cases. These are cases that are going to drop at least 50% to your bottom line. And so when you factor in that, you're looking at an EBITDA increase that's more than doubling. You're adding almost $2 million of EBITDA to a business that had $1.4 million of EBITDA. So when you look at this business on a post basis, and again, think about this, you've only added 30 cases a month to your center. You now have gone from a $7.2 million business to an $11.2 million business, and a $1.4 million profit business to a $3.4 million profit business. But your multiple is also going to go up now because, why? Because your growth rate's higher, your margin profile is better, and your future prospects are better. And so investors and buyers are going to pay up for that. So apply a 10-time multiple to that business. You've now taken a business that was worth $10 million yesterday, and by adding just 10% volume of the right type of volume, you have tripled the value, more than tripled the value of your organization. You've gone from $10 million to $34 million in equity value. So there are very few things, very few opportunities in life where you can create that type of a financial impact and a financial return for your shareholders and your organization than the opportunity that is presented right now in the surgery center market. So with that, Kylie, I will turn it to you.
Thank you, Nader. When exploring spine and orthopedics in the ambulatory surgery center space, it's important to be aware of several clinical and regulatory items. So as such, in this section, I will cover the following: procedure trends, including a look at the migration of certain spine or orthopedic cases to the ASC setting; clinical considerations, what's changed from a clinical perspective as it relates to these procedure types; and then regulatory considerations, what to be aware of with regulation and legislative changes. First up, procedure trends. So I wanted to briefly review how these two specialties have been migrating from the inpatient to outpatient and ambulatory surgery setting, just looking at the past few years. Back in 2015, CMS acknowledged that it was possible to deliver safe, effective, and low-cost spine care in a freestanding ASC, with their ruling adding 9 surgical spine codes to the list of ASC-covered surgical procedures. Just the next year, in 2016, CMS approved 13 spine codes for the ASC-approved procedure list. These particular codes were associated to over 5,000 cases performed in ASCs the previous year. So it was clear that CMS was monitoring the services being provided to its beneficiaries and continued its belief that spine procedures could be safely done outpatient. You can see that 2017 through 2019, we've had consistent movement of several spine procedures moving off of the inpatient-only list, with total disc arthroplasty being added to the ASC covered procedure list in 2018. With regard to orthopedics, of course, we know that many ASCs have been performing orthopedic surgeries for many years. However, it wasn't until the 2020 CMS Outpatient Prospective Payment System final ruling that total knee arthroplasty was finally added to the ASC covered procedure list, with the current calendar year 2021 proposal focusing on orthopedics again, and I'll touch on that momentarily. Now, it hasn't just been the addition of approved codes that is helping to shift these specialties into the ASC space. There have also been several clinical considerations that are having some impact. With the Medicare population growing, we know that this will put additional capacity pressures on hospitals to provide more acute care services, which opens the door for ambulatory surgery centers to assume that elective procedure volume. Generally speaking, we also know that ASCs have historically offered lower infection rates and higher patient satisfaction, along with more flexibility with scheduling and staffing when compared to hospitals, making it a more desirable location for not only patients, but providers and staff as well. The Journal of Spine Surgery notes that these cases are migrating in response to decreasing invasiveness of surgery, patient desire to recuperate at home, and significant net reductions in cost. Similarly, in the orthopedic space, one principal reason for the shift to the ASC setting includes patient preference for a least restrictive level of care coupled with convenience. Patients are increasingly more interested in having these procedures completed in the ASC setting. Add the current public health emergency to the equation, and the ASC trend is only expected to continue for these and other specialties. There have also been significant advances in the medicine and the technology that supports these procedures, including improvements in clinical standards. Things like pain management techniques, minimally invasive surgical techniques, patient selection, and high-defined treatment protocols. Improvements in technology and clinical standards have made it possible for these procedures to be performed in the ASC setting with favorable outcomes and without an overnight hospital stay. These are key criteria that CMS considers when approving surgical procedures for the ASC list that were previously only allowed in the HOPD or the inpatient setting. Clinical documentation, of course, is always important to ensure proper reimbursement and to avoid denials. Medicare is also consistent with focusing audit efforts on new procedures recently introduced into a new site of service. So with the recent movement of some spine and total joint procedures, we would expect Medicare to be reviewing these services for medical necessity, which means that your documentation is critical to the success of your program. In fact, just this August of this year, CMS added total knee arthroplasty to its list of approved topics for RAC audits, or overpayment recovery audits. So you want to be sure to understand the payer policies and medical necessity requirements and support that in your clinical documentation. Outcome data is, of course, also helping move these more complex procedure types into the ASC setting. At the start of 2020, there were over 300 ASCs performing total joint procedures and close to 150-160 performing minimally invasive spine surgeries, giving payers significant volume for outcomes tracking. And these improved outcomes also bode well for the providers when you're negotiating your payer contracts. And then, of course, there is the continued support from national organizations and societies like the American Academy of Orthopedic Surgeons that continue to advocate in favor of ambulatory surgery centers for the delivery of musculoskeletal care. Lastly, I'd like to just call your attention to regulatory and legislative considerations impacting the world of spine and orthopedic procedures in the ASC setting. So first, it's going to be important to review your state laws for any limitations on procedure types in the ASC setting. So for example here, we know that Pennsylvania requires an ASC notify the state in writing at least 60 days prior to the intended commencement of healthcare services which have not previously been provided at the facility. The state historically has been a little tough on total joints in the outpatient setting, so it will be important for you to review state considerations for things like this. In the calendar year 2021 Outpatient Prospective Payment System proposed rule that was released this summer, CMS is proposing to transition codes off of the inpatient-only list over a 3-year period, with this list completely being eliminated by 2024. So for calendar year 2021, CMS is proposing to do this by starting with 300 musculoskeletal services being removed from the inpatient-only list for next year. These musculoskeletal procedure codes include 69 spine codes for next year as well, so it'll be important to watch how that develops. For calendar year 2021, CMS is also proposing to add total hip arthroplasty to the ASC approved list. Now this is significant because it typically takes several years to migrate a procedure type from inpatient only to outpatient to then finally being approved as an ASC covered procedure. But with this particular procedure, we've seen this move more rapidly over just the past 2 years of rulemaking. The final ruling is expected to come out a little bit later this year due to some delays with the public health emergency. So instead of the November 1st deadline for the final rule, we're looking more at a December 1st deadline. And then finally, we have advocacy efforts continuing. These efforts continue to bring more and more of these specialties into the ASC setting. We have lobbyists and other advocates, including National Medical, that continue advocating in Washington, D.C. to include more procedures in future rulemaking to only further support the shift of these specialties into that ASC space. And with that, I'm happy to turn things over to Scott Allen.
Thanks, Kylie. As Hunter pointed out, bringing ortho and spine to your ASC can be very impactful. I'm excited to be here today to talk about managed care. I think an often overlooked step in that process. So we're going to start simple today and then get into some more complex stuff, but I'll jump right in. So the first item here seems pretty easy, but the fact is most ASCs we encounter do not have complete contracts. Oftentimes I'm encountered with bringing on new cases. We want to bring new ortho surgery, a new spine case in, but if you don't have the complete contracts, crosswalks, or amendments, you're not going to be armed very well to make the right decisions and to understand if those cases that you want to perform are going to be profitable, or if the cases you may already are performing are profitable as well. So the first step, of course, is gather complete contracts. I recommend reaching out to your provider rep to identify who that person is and understand that they are the ones to contact to get those complete documents. But you want to make sure you have, as I said before, fully executed agreements to start the process. Once you have your complete contracts, it's important to understand how those contracts are interacting with the cases that you're performing. When thinking about ortho and spine, you have a lot of things, overhead costs, implants, to worry about when thinking about your commercial managed care contracts. So I recommend looking at those cases in a deeper format. We'll get into the case analysis later on in this presentation, but right now just thinking about getting the complete contracts, understanding what the payments are to your cases to make sure that what you're performing, as I said before, is making money. The third step here is arming your staff with those complete contracts. We want to make sure that the front desk, the rev cycle staff, has knowledge of the contract and understands things like the implant language, days to appeal, days to submit claims, all types of information that is going to be detailed in that contract. If you don't have the complete contract, how will you ever understand exactly what is happening behind the scenes throughout the rev cycle? In addition to that, I think it's also important to have the front desk staff track the insurance products. So you want to make sure you understand within that commercial business what is the frequency of the HMO product to the PPO product would be a good example. And also understanding things like fully funded and self-funded plans. These are all things that are going to come to play when working with that payer, and also when thinking about bringing on ortho and spine. Those two are going to be most likely very heavy self-funded employer-type surgery plans. So definitely something to think about when you're bringing on the ortho and spine cases. So the next thing here, once you have your contracts, you've laid them out, you have all the terms, I think understanding the commercial ASC payer methodology in relation to those ortho and spine cases will be very important. And we're going to dive into a couple different types of methodology here later on in the presentation. But for right now, I think just understanding if the agreement that you have in place is a fee-for-service, meaning that you provide a surgery and you're paid for that surgery, or is it a bundled arrangement, meaning do you have other ancillary services that will be included in this payment? For example, you may have an agreement that could be bundled with anesthesia or maybe PT. So understanding if you do have an agreement that requires prior or post-surgery requirements included in that overall surgery reimbursement is important to understand. And other agreements could be risk-based or value-based care. So just making sure that once you have that complete contract, understand the products that are involved with it and understand how you are paid for services that you're providing. I often find centers will not understand that the anesthesia and ancillary services such as the professional provider service is actually included in a one payment overhead cost. So just making sure that you're not caught off guard with that by having the complete contracts, understanding those terms, and applying them to the cases that you're performing. The next one here is a next step. So once you have your contract terms, you understand how they're paying, you want to look at what your overhead costs. So looking at ortho and spine, these are two areas where it's easy to maybe not understand fully what's happening behind the scenes. For example, if you have a provider that's doing shoulder repair, do you know if he or she is utilizing one anchor or two or three anchors, right? So understanding the frequency of the supplies that you're using, the overhead costs, the OR time will be very important to add to that equation of understanding what cases you're performing and are they making sense for your ASC. And this would apply to cases that you're currently performing, or if your goal is to bring in ortho and spine, you can conduct this with your current managed care contracts to make sure that what you want to bring on makes sense. And if not, of course, reaching out to the payer rep armed with this sort of data is going to be an important next step for sure. And segue right into that. So once you identify the payer rep, you gather complete contracts from him or her, then you have data, you've armed yourself with your overhead costs, what's not making sense with the contract. You want to make sure that you work with them, right? You want to provide them any sort of weak points, understand patient population, maybe patients that you are seeing right now aren't making it to the ASC for whatever reason. I think a very solid strategy and a strong message for ASCs is, are you able to provide the same cases at a lower cost setting? So potentially you have an ortho provider that may not be able to bring a case to your ASC because maybe the contract does not include implants, or the overhead cost or reimbursement is just not there to perform that case. Those are the sorts of items that you're going to want to bring to the payer rep's attention to get higher rates and remedy that situation. So now we're going to dive into a couple of different methodologies and apply those to spine and ortho. So a pretty standard methodology for ASC reimbursement is grouper methodology. This is where you would have maybe 1 to 9 groupers, a crosswalk, and associated codes would be assigned a group and then assigned to that associated payment amount. The thing about grouper methodology to think about when adding ortho and spine is that you're definitely going to want to make sure that you have a separate carve out for implant reimbursement. So for example, if your group 1 starts at $600 and group 9 ends at, $8,000, that may not be enough to capture everything that you're performing. So groupers often require carve outs, carving out codes that may not fit into the grouper reimbursement for 2 reasons. Maybe they're not high enough for the grouper, or the contract does not have a separate implant reimbursement, for example, invoice cost plus. Therefore, it requires you to carve out those cases and codes as well. So for groupers, not only as I said, are you looking for lower reimbursement within those groupers, but you're also looking for cases that may require implants. And if that payer contract does not have separate implant reimbursement, you're going to be stuck with carving out a lot of different codes and cases that require additional overhead costs. The second one here is the APG, APC. This is more of a Medicare-based methodology. This is one when applying to spine and ortho situations where you may or may not have that code Medicare approved. So if a contract is following a Medicare-based reimbursement, the first thing you're going to want to do is understand how are they going to price the codes that are not priced for Medicare. Will it be priced percentage of bill charge, meaning if you bill that code, they'll pay you a percentage of those bill charges, or will you have to come up with some sort of carve-out amount to capture that reimbursement? And just be aware that some payers may in fact say that if it's not on our list or not payable per Medicare, we're not going to pay it either. That's one thing to look out for. A second thing to watch out for is if that payer is offering Medicare language, make sure that the language in fact does follow Medicare 100%. We see commonly that they'll use Medicare language or Medicare-like terms, but in fact that rate does not follow 100% of that current local Medicare rate. The third one down here, similar to the APG, APC, Medicare, this is the Enhanced Ambulatory Payment Groups. This is a 3M product, and essentially the same concept, but on top of the bundling, they have a packaging of codes and cases. So if you do have a contract with that methodology, the best bet is to make sure you have all the tools and resources you need to analyze those rates. And you can go to the provider rep at the end of the day and ask them if you need to get more information or understand how a case is pricing. Often payers also provide online portals and tools to price cases as well. And the last one here, of course, pretty simple, percentage of bill charge. Of course, the most favorable one to have. This would allow you to pretty much bring on whatever you wanted to, not have any sort of restrictions. Whatever you bill, you'll be paid percentage of bill charge. This may or may not include the implants as well, so something to watch out for. And if you do have a percentage of bill charge contract, looking at your charge master will be very important to understand, of course, what you're going to be paid if you do bill out at the specified rate, but also the payer will have pretty strict language around increasing those charges at any time, annually or at any time, adding new codes or cases. So percentage bill charge contracts, very favorable, yes, open, free, but oftentimes the payer will have regulation in there to make sure that what you're charging out is not too high. Great, so this is, we touched on this earlier, this is the multi-procedure logic and case analysis. So this is really the essence behind why we at National Medical feel the case analysis is really the superior way to analyze your managed care contract. Typical, we see administrators to take, top 50 codes maybe, and they'll throw them into a spreadsheet, they'll put Medicare rates alongside of them, and they'll think this is okay. We are understanding how cases and codes are paying. So you're definitely cutting yourself short with that. What we want to do here is a case analysis. So instead of looking at the codes, code by code, we want to understand how the case is set up, what codes are in that case, and the code combinations with that. And so once you understand how the case looks, you can then understand how that payer will adjudicate that case after paid. And so the case analysis, as I said before, is the only way to get the exact amount of reimbursement when that case is in a true case format. And the real essence behind that is the multi-procedure logic. This is a term in your managed care contract that dictates when you perform more than one code in the case, how those codes will be priced and reimbursed. For example, the Medicare standard is 150/50, meaning if you perform 3, 4, 5 codes on the claim, Medicare will pay the first code at 100%, second code and all subsequent codes will be paid at 50% of reimbursement. Commercial payers will oftentimes adjust that to maybe only pay 1 line or 2 lines or discounts below the Medicare standard on the secondary and tertiary lines, 25% or even 0. So definitely when you get your hands on those managed care contracts, this is one of the first areas that I go to. It's just understanding, when you have a case that maybe has 3 or 4 or 5 codes deep, if you're not being paid for those, you want to make sure that you're getting paid enough for that primary code. And then you may hear that, I'm sorry, if we could take a step back. I can finish up on the last slide. But you may hear that people compare their managed care contracts to Medicare. What I want to do is just point out that the case analysis is a great tool to do that as well. So once you lay the case amount out, you get the bottom line adjudication of how that payer will pay that that claim or case, what you want to do is line up the Medicare reimbursement right next to that. And what give you is an apples-to-apples comparison on what your reimbursement is. And we at National Medical may take 3,000 cases at one time to analyze this, but this is a great tool to not only understand how you're being paid currently for your ortho and spine cases, how you can be paid if you want to do those ortho and spine cases, but also any sort of weak points are brought out, identified very quickly in proposals and stuff from the payer. So using this for all types of purposes once you get the data in the right place is what we recommend. Great. So after having your base in place, having the complete managed care contracts, understanding what those terms say, arming the team with the knowledge, performing a very detailed case analysis, looking at your overhead costs compared to those case analysis, I think you'll be in a great place to go to the payer and talk about the current cases that you're performing ortho and spine that may not be making sense, or talk about potentially bringing on cases, ortho and spine, that you want to your ASC. And as I said before, one of the best leverage points currently right now, I think with COVID going on, is patients, aren't wanting to go to the hospital, right? And in addition to that, it's costing them more out of pocket. It's costing the employers more, the payers more. So any sort of work you can do to analyze exactly, how many cases are being performed outside of your ASC, and then throwing that into the mix is very helpful when going to the payer and talking about ortho and spine. In addition to that, if you have knowledge of the provider that you want to bring on, but he or she has not performed cases at your ASC, I think including their name into the proposal, into the mix, definitely helpful. The payer can analyze those doctors based off their MPIs to understand exactly where those cases were going prior. So just making sure that you have everything prepared for that payer, and you should be very successful with all the tools I provided to you today.
So as we've all seen, there's been major, and we've talked about here, there's been major movement within orthopedics and spine. Great opportunity, exciting time. There's a lot to do, a lot of work in front to execute on it and to make it work and to have happy patients and great outcomes. And so really there's a handful of steps that we would say to kind of big picture pull this together. First and foremost, you want to make sure that you are developing your protocols, your clinical protocols. And so thinking about what you've done from a clinical standpoint in the hospital, your best practices, understanding your surgery center environment, working with experts to make sure that you tweak and adjust that and create a plan, and that you are taking on the right patients, et cetera, that really fit in the surgery center environment. Obviously, those are all from a clinical standpoint. It's not necessarily our world, but we've watched closely, and the centers that are doing the best job have really put a lot of diligence into that process on the front end. Secondly, bringing in how do you get those patients to make that move? It's having a good patient outreach program, having great education at the surgical practice site, and knowing how to communicate to a patient who might not even know what a surgery center is, why they might want to, at least, not that you're trying to sell them in one way or the other, but at least educate them, in terms of what the experience environment would be like in a surgery center versus a hospital outpatient versus an inpatient. My experience has been very few of the practices have materials, have collateral, and really even have the conversation with you about that, including the financial impact on the patient. So that's important. Scott just obviously went into great detail as to what to do from a managed care contract standpoint, and all I'll say on that is it sets the stage for your success or not financially, and how well you negotiate your contracts. That is what you are asking for. So if you don't ask for the right number and you set yourself up incorrectly, then you're kind of set up to fail from the beginning. So that is so important to get right. having great front-end processes where you're getting the information in correctly from the patient, that you're doing getting the pre-auth, and sometimes the payers will tell you don't need a pre-auth and it's a spinal fusion, and I would make sure you get that in writing if they tell you that, because these big ticket items, the payers are clearly looking for reasons to deny it for lack of medical necessity and other reasons. So really important to get all of that right so you can get your claims out the door clean and paid quickly. Financial counseling, really having someone there who can talk to your patients, walk them through all of this, and again, educate them on the financial impact, making sure you're collecting correctly up front. If you don't do that, it's very hard to collect on the back end. And that feeds right into the entire process, the entire revenue cycle process, from coding, getting those claims in, your payment posting process and flagging, making sure you're not missing out on implant payments, because obviously that's an enormous expense for you in this business, accelerating the time frame to get those payments. All that's very, very important, having a great appeals process. And then ultimately, at the end, having really sophisticated analytics built around all these programs so that you make sure that everything you're doing, one, you're taking on the right cases. When you take them on, you're delivering on those from a high quality standpoint, and then financially that you're collecting on what you should collect and getting paid properly for that. So that really concludes the presentation part of this. I know we've had a lot of questions come in here. So I think with that, one, we'll thank you guys for your time here and listening, and we will jump right now to a Q&A here for a couple minutes before we break. And also, we have more questions. We have more questions than we'll be able to answer here, so we'll try to answer the ones we can right now, and to the extent we can't, then we will, I think we have everyone's contact information. We'll reach out to you and try to get your questions answered.
Yes, absolutely. Thank you so much, Nader, Kylie, and Matt, for that great presentation. And let's just go ahead and dive right in here. As Nader mentioned, we've got a lot of great questions, so we'll try to get through as many as we can. So the first question we'll take then is, the attendee asked, you mentioned total hips proposed in this year's ruling. What does the reimbursement look like for ASCs for this?
Yeah, so as I mentioned...
Yeah, go ahead. Yeah, go ahead.
Sorry, yes, as I mentioned, CMS is proposing adding total hips to the calendar year 2021 ASC approved procedure list. So the reimbursement as it's being proposed is just under $9,000 at a payment rate of $8,923.98 if the procedure is approved. And of course, there are some regional calculations to take into account there as well. Several organizations are challenging that reimbursement in their formal comments to the proposal, but we should know more in early December on whether or not this is formally put into their final ruling.
Excellent. Nader, did you have any hook-ons there?
Nope, Kylie's got it.
Yeah, knocked that out, added some great clarity there. So the next question then we'll take is the attendee asks, is a 50% margin per case reasonable with the cost of implants being $4,000 or more?
Yeah, so that's a really good question. So I would say strictly from a Medicare standpoint, no, that's probably a little bit high. First of all, obviously I think a lot of people now are looking at negotiating implant rates down as it relates to Medicare type cases. So that's one thing, is I think everyone who is making the decision to take, for example, a total knee at $8,600 plus whatever your index adjusts to. Yes, if you have a $4,500 implant, et cetera, that cuts you to 50% right there. So what we've seen centers doing on a Medicare basis is looking at all aspects, every line item of their expense, and trying to see what they can do to make that as profitable as possible. You probably won't get to 50%, but when you mix that with your commercial cases, and if you've negotiated good contracts, from a commercial standpoint, 50% has frankly been a conservative number. We've seen 60 to 70% margins on that line of business, again, with good contracts. So when you kind of blend all of it, I do think blend it and attack your cost structure. Now with that movement to Medicare, I do think that that's a reasonable number.
Definitely. Thank you for pointing that out there. The next question we'll take is the attendee asks, how realistic is it to take on complex cases given comorbidities that often require more monitoring and therefore overnight stays?
Hey, Kylie, do you want to jump into that one?
Sure. Well, we're seeing it happen really all across the country in the ASC setting right now for several of the reasons mentioned previously, being the new clinical protocols, the improvements in technology, the minimally invasive approach to these types of procedures that are actually making it a safer place of service for patients to receive this type of care. Of course, it's always the clinician and the surgeon's discretion when screening their patients to find what's appropriate in the ASC setting, but we think that the advancements in these clinical trends and technologies and procedure technique is what is really helping ASCs to shift this more complex case volume into their setting.
Perfect. So this next question here, I think, provides the opportunity to sort of like revisit some of the conversation around the trends, the drivers behind these trends. So the attendee asks, what is the driver to move more specialties to use in the ASC?
What's the driver to move more specialties to the ASC? Is that the question?
Yeah, I believe so.
So I think it's what we hit on at the beginning, really. It benefits the patient from a cost and convenience standpoint, the surgeons, again, flexibility, control, economics for them, and certainly economics for the payer. And it's all couched in terms of what Kylie just mentioned, that it's really important that the right cases go, and so that everyone remains and continues to deliver, great outcomes. And we've seen, if anything, our surgeons across the country be very conservative and leave things longer in an inpatient or a hospital outpatient until they're extremely comfortable and they have enough experience and they have enough data to feel comfortable with the quality that's going to happen in the surgery center. So I think it's all those trends.
Great. Yeah, thank you for revisiting that. And I think that the next question kind of works as a follow-up. So, and I think it'll be the final one we take. So any closing comments would be great as well. So you mentioned that payers want to see more cases in the ASC. The attendee then asks, who is the real driver to get more doctors' cases to the ASC?
So I think it's one of the things that I'd mentioned earlier is, again, there's a lot more cases belong there than did in the past through technology and such. But really, I think it is having a good process at that surgical office where you're communicating and educating and informing the patient. And if so, I mean, I just on a personal level, my son was having knee surgery during COVID, and when we went to schedule it, they said, okay, on Wednesday, okay, it'll be Wednesday in the hospital. And I said, well, why would it be? Out of curiosity, does a surgeon not practice in a surgery center? And she said, oh, no, he does. He does it 3 days a week in the surgery center. That was just one of his hospital days. And she said, why? Would you want it in a hospital? Or would you want it in the surgery center instead of the hospital? And I said, well, of course, there's COVID and all of that. He's 17 years old. Doesn't, there's no need for that. And it's same-day procedure. And they said, okay, sure. So point there was there wasn't a thought process there from the surgeon's office that might be preferable to us. It might be preferable to the surgeon. And so that would have been a missed opportunity for a case to happen in a surgery center when, in fact, I wanted it there. So luckily, I understand this world a little bit, and so I asked the question, and we did it in a surgery center and had a great experience and a great outcome.
Excellent. Thank you so much. I think that's a great place to wrap for us. So I just want to thank Nader, Kylie, Scott. That was a great presentation. And National Medical Billing Services, thank you for sponsoring today's webinar, helping us put this together. Everyone enjoy the rest of your day, and we look forward to having you join us for future webinars.
Great. Thank you, everyone.